Thanks very much, Jessica, for the kind introduction. Thanks, Sebastian, for recruiting me to do this today. It's really my pleasure and honor to be talking to you all. I understand we've got a mix of faculty and staff at UW and also members of the community out there and patients. So welcome to everybody. Hopefully I hit all the points. It's kind of a broad ask, but hopefully I kind of hit on the points and talk about some of the advancements and highlight some of the things that UW is doing in the field of reproductive endocrinology and infertility to move things forward for access and evidence-based and updated fertility care. So I'm particularly happy to talk about this at the end of June. June is World Infertility Awareness Month, and one of our long-term goals always is to improve awareness in the US and worldwide about the issue of infertility and need for fertility preservation and considering future family building in people's reproductive ages. We also have, interestingly, in April every year, there's a National Infertility Awareness Week, which we also take advantage of to really try to elevate this issue on a local, state, and national way. But I'm very appreciative that various international organizations have identified June, again, as World Infertility Awareness Month, because it really is an international issue. So again, infertility is really a global public health issue, and it causes a great deal of existential suffering for people involved, for patients themselves, their families. It's something that's kind of under-identified, and I think because people don't often talk about it, it can be a very stigmatized disease or condition, and so it's often silent suffering, especially typically for men patients will tend to, sort of not involve their community or their family in talking about the suffering that's involved in infertility. And as you can see from this World Health Organization statistic, it might have come out in 2023 or 2024, but recently the World Health Organization did a really good deep dive into the data worldwide, showing that it really affects a lot of people around the world. What they published was that 1 in 6 couples experience infertility, and that's sort of like at any given point. If you actually look at lifetime infertility, folks who have experienced infertility at any time during their lifetime, that number goes up. The other thing to note is that the World Health Organization actually was just looking at data based on couples again, and we know that there's a population out there that is suffering from infertility or needing fertility assistance or treatments who are not in a standard, cis heteronormative partnership. So we've got lots of folks out there who aren't even included in this category and in this epidemiologic overview. So more than just the 1 in 6 couples is the bottom line. So our goal today in presenting this in World Infertility Awareness Month is to raise awareness within the UW community and outside the community to talk about some of the challenges we face and talk about some of the advancements, in particular, things that we're doing at UW. So around the same time that the WHO came out with the this really nice, again, deep dive into the epidemiology of infertility, ASRM was also working on providing a more robust and inclusive definition of infertility. ASRM stands for the American Society for Reproductive Medicine. That's kind of our national professional organization. And the problem was that in the past, the definition of infertility, again, has been very heteronormative, and it hasn't really included folks who have known reproductive abnormalities. It was basically just saying, if you're having regular unprotected intercourse for 12 or more months and not pregnant, then you're infertile. But that's missing a whole swath of the population who could benefit from treatment and should perhaps be seeking treatment earlier than the 12 months. So ASRM got together with, their expert panels and came up with this more robust and inclusive definition. Um, and you can see one of the things that we continue to sort of focus on and emphasize is the fact that infertility is truly considered a disease. I think out there in society, sometimes people feel like, oh, this is like an elective thing if you want to have a family. But the American Medical Association, the World Health Organization have all identified the fact that infertility is a disease and really should be getting the focus and research and sort of support, just like any other disease process. So again, ASRM wanted to highlight that we're talking about a disease, condition, or status, and that it may be characterized by inability to achieve a successful pregnancy for any number of reasons that may be able to be identified prior to this 12 months of trying. So if somebody knows that they have blocked fallopian tubes, or they know that there's sexual dysfunction, they're not able to have, intercourse without pain or to ejaculation, there's going to be reasons even before this 12-month time to seek care. And there's also the need for medical intervention, again, that's outside of the heteronormative. So for single people, for people in gay or lesbian relationships, we know that we need third-party reproduction to be involved. And so that's donor gametes, donor eggs or sperm, donor embryos, or some patients who can't safely carry a pregnancy, or may have had their uterus removed or born without a uterus. We know right off the bat that that person is going to need a gestational surrogate. So again, this is a more inclusive definition. Ultimately, they come down to this, this kind of idea of what is sort of normal, expected when when egg is exposed to sperm regularly on a monthly basis. We should expect that 85% of couples or people exposed to sperm on a monthly basis will be pregnant by 12 months if they're under 35. As you can see in this third bullet, there's this interesting setup where ASRM has appropriately said, okay, if you've tried for 12 months under 35 and you haven't yet conceived a pregnancy, this is infertility and you should seek care. As you get older, while it may be even harder naturally to conceive as the quality of egg and sperm decline, the recommendation is instead to seek care earlier. And so that is a bit of a conundrum in people kind of understanding why those two things don't go together. But the idea is that because, especially if people want to have a larger family than one child, we need to get on the treatment earlier rather than later, because fertility is declining rather rapidly. So while it is more normal to take longer to conceive as you get older, ASRM and experts like us recommend that, in fact, people over the age of 35 not wait for the 12 months, but in fact just wait for 6, and even over the age of 40 to seek evaluation immediately, so that any abnormalities or inefficiencies can be identified and we can move more quickly. So it's a little bit of a cognitive dissonance in that, but that's the reason for that recommendation for evaluation. And then again, ASRM really wanted to point out that nothing in the definition should deny or delay treatment to any individual, regardless of their relationship status or sexual orientation or gender identity. So again, a really nice, more robust kind of call to action for infertility. So I have this interesting conversation with patients pretty frequently where, and with learners, where, sort of sex ed in school often has to do with avoiding pregnancy, avoiding STIs, avoiding pregnancy, but it almost never talks anything about what is normal for fertility. What if you want to in the future have a family, carry a pregnancy? And so many people come to us with really very little awareness of what to expect when they're considering building a family. We do recommend a discussion with primary care providers so that patients will, before they even, stop their contraception or think about starting to try to conceive, that they talk to their primary care provider to do a little preconception consultation. And that would involve things like, finding out if medications are safe in pregnancy. Are there any practices that, should be tapered or stopped prior to pregnancy? And then also, are there any kind of red flags in your health in thinking about ways that you might find challenges when you're trying to get pregnant? So these are things that certainly do not have to be done, and again, should with an REI physician. These are things that can be done with a primary care provider in OBGYN or in internal medicine or family medicine, just to kind of do a little bit of that education and also identify those patients that maybe need to be referred immediately, either because of age or because of some obvious dysfunction, and so not making patients wait as well. So, but in general, about 85% of heterosexual couples who don't have sexual dysfunction are able to have productive intercourse on a monthly basis. Under 35 for the woman, will conceive in a year. And so that's kind of, again, something that I think we see many patients who, get frustrated after just a few months and feel like, they were told they weren't careful that they were just going to get pregnant, very quickly. And in fact, that's not the case. Reproduction is a little bit inefficient, it turns out, even in a normal range. There's some methods here to just help folks who are trying to conceive, and they can be helpful. Studies have shown that just an awareness of a woman's body and their regular cycles, and including, there's been some studies showing using apps to track everything and highlight the sort of fertile window, can be helpful with increasing pregnancy rates. So these are just some of the things listed there. I did point out the privacy issues that come along with apps. So we have most of our patients do use apps to keep track of things, which is great. We certainly are respectful of folks who feel uncomfortable with that, because it's often, we don't know what data are being shared with these apps. So an old-fashioned calendar is great too, but it is helpful to kind of track those things and kind of get a sense of what the timing is right for a particular person. So this just goes back to that question of age and what should be expected at a given age for fertility rates per month. Both of these things are out of ASRM, so the chart on the left. And then ASRM also publishes some really nice patient-focused educational materials on their website called reproductivefacts.org. For providers, they also, you don't have to be an ASRM member. You can access practice committee documents and ethics committee documents on the ASRM website, asrm.org. And that can be super helpful for primary care providers, or obviously we use them all the time in REI as well to help. But this reproductivefacts.org is patient focused, and it can be used and helpful for patients who are out there trying to figure out, just like it says, how do I optimize my natural fertility and what should I expect? So again, because a lot of this is not necessarily, taught and may not be understood sort of within families, and talking about that as well. So a few resources that can be super helpful. And I think there's sort of out there in the media, you see a fair number of celebrities or famous folks out there who might be having babies in their late 40s or even 50s, and maybe not sharing that there might have been some assisted reproductive technologies used to help. And so I think we often will get a misunderstanding too from our patients coming to see us in their 40s, mid 40s, that there are real, and we're talking about egg producing patients, so patients with ovaries. There's a real decline, as you can see in this chart. Usually kind of happens at about 38, a little bit more rapidly. And so we really see a decline in that. And that can sometimes be misunderstood, or when people feel like they're healthy, otherwise having regular periods, there's still this decline in there. egg quality. And so we see a real drop off there and an increase in risk of miscarriage. So again, all about education, and that the nice preconception discussion with a primary care provider can go a long way to help with anticipating that. So what is out there causing infertility? This slide is from the NIH, and it just is a nice graphic to kind of broadly hit on some of the issues out there. It's important for folks to know, patients and providers out there, and us to remember that there's a good portion of infertility that we, still don't understand. And generally, we say about 15% of the couples we see will have unexplained infertility. All the testing we do, we don't see a reason. There's also a question out there about, is infertility increasing over these decades? That's a really tricky one to wrap your head around. It seems that may be the case. However, one of the trends with that has to do with age. And so if you sort of control for age, it may not be that fertility rates are increasing. However, IVF utilization is increasing. There are more and more children conceived through IVF born each year in the US and across the world. And we are seeing more impacts of environmental exposures, chemical and toxin exposures, potentially from forever chemicals that are out there, like the PFAS and microplastics in the environment. So there's reason to be concerned, I would say, but we don't have clear definitive data. Again, the WHO came out with these numbers that are higher than they've been before, but many people in the world of epidemiology feel like that may just be because there were questions were asked in a better way to really get at the rates of infertility. Anyway, so I'd say it's an open question, but certainly the age at which patients are seeking to grow their families is increasing. And so as you can see from the left side of this slide, age affects both men and women, both eggs and sperm can be affected by age. Happens a little bit earlier to the eggs than to the sperm. And it's not, certainly sperm can, from a 70, 80-year-old, can still successfully fertilize an egg, whereas with eggs, we really are talking about 45 years old-ish as being, it's very, very rare after the age of 45 to have an egg that is successfully fertilized. So it's a different impact on egg versus sperm, but does infect both. And there's I talk a little bit later on about, what can be done about that. Does something have to be done about that? We meet a lot of patients who have, are doing the responsible thing and making sure they're in a good situation from a relationship standpoint and a professional standpoint to grow their families. And then they're met with, with challenges based on their age, and it's unfortunate. I also should have said earlier that I work part of my time at the VA as well, and we have done some computer-assisted telephone interview work looking at rates of infertility in veterans, and those rates seem to be particularly high. Some of our data would suggest that almost half of veterans will experience infertility at some point in their lifetimes. And so this question of age and exposures is particularly relevant for the veteran population when it comes to being in a place where they've separated from their service or finished with their deployments, feeling like they're in a good place for pregnancy. And then also part of their military service often involves exposures to things that, have not been fully elucidated as far as their risks to pregnancy and fertility. On the right side, you can see some of the issues particular to sperm, which include one thing that I think a lot of men out there aren't aware of when they're using testosterone, that is sort of sold or is used for feelings of strength and virility, and yet it actually is very counterproductive to sperm production. And so that's something that's kind of a not always people aren't always aware of that out there in the community, and so that can be a real shock when patients come in and feel like that might be helping them when in fact it's the opposite. And then for women, we have some certain diseases that we see again, and these are the things that might be identified in a preconception visit, such as polycystic ovary syndrome, or somebody without periods because they've actually had early menopause. Endometriosis and fibroids can impact fertility as well, and damage to the uterus and to the fallopian tubes can be an issue as well. And then in the middle there, again, we talked a little bit about chemical exposures, exposures to chemotherapy, radiation. Some broad chronic diseases can certainly impact fertility, as well as exposures to alcohol, tobacco, pot. Those things are all things that can be assessed at a preconception consultation, or certainly by us in REI as well. So what we see a lot, and is one part of our job that I think we all feel very privileged to be part of these conversations with patients who are feeling incredibly impacted by this family building journey that they've been on. They always thought that this should work out for them. This was in their, in their family building goals throughout life, and then they're struck with these challenges. Can be incredibly, incredibly stressful. Really high rates of anxiety and depression. And then there's this concern that this sort of catch-22 of, well, is my anxiety and my feelings of stress worsening my risk of fertility? So it's a really tricky cycle to be in. Certainly, again, it's very stigmatized. I've done studies asking, patients about with and without fertility, how they feel about fertility as a disease versus a disability, as a condition. And it was really interesting that what comes up is patients feeling that somehow God was, was sort of like judging, am I not worthy of being a parent? I mean, it's a remarkably layered and difficult situation to be in for patients, and to feel that judgment potentially from folks who haven't struggled with fertility issues. It also, both in this country, but especially in some other areas of the world, really increases people's rates of intimate partner violence, domestic violence. It can be, a reason why a person can be ostracized from their family, divorced, separated. In some cases, it may be related to a sperm problem, but can be blamed on the female partner, unfortunately. So it can have some, extreme impacts. And then there's the economic burden as well. It is not a disease process. It kind of goes back to my point about the importance of the WHO and the AMA talking about infertility as a disease. Sometimes insurers and policymakers don't treat it as such and support it as such from a funding perspective, both for research and for ensuring clinical care as well. So as a result, it can be extremely economically burdensome, and that adds to the difficulty with relationships and just with the family life as well. It also tends to really cause a sort of a situation of haves and have-nots, which is compounded, as we'll see in a minute, by what is accessible, where, who's affected, what about these technologies that are emerging in our field as well, what's available to people who have money and who don't. So it's really remarkable impact on folks. The other thing I would say here too is that I've been struck over the years, and studies have backed this up, in patients facing cancer and facing limitations to their fertility because of chemotherapy or time limits, or surgical treatments, that oftentimes patients are more distressed by the impact their cancer treatment will have on their fertility than by their actual own health concerns. And so that seems kind of unbelievable, but when you've talked to enough patients and seen these data, it's out there. So it's, again, an incredibly stressful situation. So as I mentioned, touched on a little bit, we definitely have some disparities out there, unfortunately, both in this country and definitely around the world. In some places, infertility care and fertility treatment is not even available to parts of the population, whether it's because of their characteristics, their sex or gender minority status, or because of where they live. But there's many swaths of the world where infertility treatment is just not available at all. And the barriers in the United States have to do, often align with rurality, with race and ethnicity. Cancer patients are often faced with having to move very quickly to make decisions about whether they will be able to preserve their fertility. And that is something that folks without good insurance or without access to high-tech care will then be, left out. For sex and gender minority folks, LGBTQ population, that's, again, especially across the world, these treatments are not often available to those communities. And they tend to obviously have higher needs in this field. And then we're particularly interested, well, we're interested in access for all of our communities, but we have a particular sort of center of excellence and focus here at UW for patients with higher BMI. And I'll show in a few slides here something we just published on that. But that is an increasing point of disparity across the country, as especially IVF is provided by more and more private clinics out there, and they're being purchased by private equity organizations, which is, a theme across a number of different components in medicine. But in the REI world, it's a real issue. And when that happens, often populations that have traditionally lacked access are even further disconnected from access, including patients with higher BMIs. And so, for example, at this point in our in the community, in the state of Washington, in the area, WWAMI, and including even Oregon, we are, feels like, and I think it's true, the only clinic that is seeing patients with who need IVF with BMIs over 40, 45. We have no limit. And so we're seeing that, increasingly around the country as well as the region. So the other bullet point here points out that our field, our academic field of REI, is really tackling right now a supply and demand issue with inadequate numbers of trained REI providers out there and increasing demand for services. So there was a white paper in the last few years just trying to figure out how do we incentivize providers? How do we train enough providers to provide the care that's needed? So you can see it's kind of an unfortunate mix of issues with access and disparities right now. This map is from Resolve, which is the National Infertility Nonprofit organization to support patients and providers. And Resolve tracks the bills that are working their way through the state legislatures. And it has certainly gotten better over the years, slowly but surely. The goal is for all states to have some amount of legislation around access to fertility treatment and fertility preservation treatment. So the different colors, I don't know how it's probably big it is on your screen, but sort of the gold states are IVF and fertility preservation coverage. That's kind of ideal. And then the different states with the different colors may have a mix of those, sometimes just fertility preservation, sometimes infertility care, etc. Sometimes there's age limits. Whenever you're looking at these state efforts, there's always an issue about what kind of insurers are we talking about? Are we talking about public employees, etc. Anyway, so there has been active work going on in Washington State and in Oregon to try to push these things forward. And we will continue to do that. And I'll invite folks to take part in that in a few slides here. And it sounds like there's a fire drill right now, but it just sounds like a fire drill. So I will continue. So diagnosis, there's a number of, I didn't want to go into too many of the details, just trying to cover a lot of different things, but, our diagnosis generally involves our evaluation to look for a diagnosis behind the infertility, generally involves lab tests for hormonal evaluations, ultrasounds, hysterosalpingogram, which is an X-ray test of the fallopian tubes for people with uterus tubes and ovaries. And then for folks with sperm, we've got the semen analysis, and we have some extra adjunctive tests for the sperm that are sometimes used as well. So, that kind of mostly has to take part in these specialized centers like ours here. Sometimes you can get some of this testing done, outside in the community, but generally, in order to provide formal semen analysis and especially higher tech things like DNA fragmentation, you're talking about a urology practice which here we have in the urology department, along with an REI type of practice as well. So some advances in the world of diagnosis, they would include things like genetic testing, both for the patient themselves and for embryos that might result from in vitro fertilization. And one of the things that has been becoming more obvious too in research around the diagnosis of infertility is that we're seeing more and more that a diagnosis of infertility often is associated with future risk for chronic disease like metabolic disease, heart disease as well. So it's an interesting, sort of in a similar way that pregnancy and issues that come up in pregnancy may foretell some issues later in life. We're starting to see that as well in infertility as well. So I just wanted to use this opportunity to highlight some of the work that, again, our team is doing. So Dr. Mia Yang is one of our PhD faculty in REI. She has an appointment in ice cream as well. And she's doing work on, and this is this picture on the right lower corner is a picture from Dr. Yang. She's doing some work looking at the genetic testing that is offered for embryos and showing that the pre-implantation genetic testing that we can do may not be as good a predictor of live birth outcomes because there can be some self-correction. And so this is just amazing work that she's doing in the lab to try to get at perhaps limitations on our current available diagnostic testing and also opportunities for improved testing and just a better understanding of what happens in this black box of reproduction once we no longer can watch the embryo. So I could talk, for a long time about treatment for infertility. Generally, we want to make sure that we're focusing on any underlying medical issues that may be exacerbating or causing fertility issues, such as thyroid disease, for example, is a good one. Or if somebody has, an issue with low testosterone because of an issue with low FSH production or something, then we can work on those medical issues to try to improve sort of a more unassisted improvement in fertility, and also an identification of exposures, decreasing exposure to heat, decreasing exposure to chemicals, tobacco smoke, pot, etc. So we never want to forget about those things. Better control of diabetes will, improve fertility. And then we've got, once we've sort of optimized those things as much as possible, we've got ways to directly improve the efficiency of the reproduction itself. And that can be through medications to help with ovulation. It can be through techniques to wash and concentrate sperm and get the timing right for exposing sperm to egg with intrauterine insemination, using donor sperm to similarly expose egg and sperm. Our assisted reproductive technologies, or ART, basically means in vitro fertilization and intracytoplasmic sperm injection. And that's anything where we're stimulating the ovaries, taking the eggs out surgically, exposing them to sperm in the lab, and then producing embryos for transfer back to an intended parent's uterus or to a gestational surrogate. And so that's a fair amount of what we do and sort of the highest tech thing that we do, but not the only thing that we offer. The grouping of third-party reproduction involves any time where we've got a third party involved to provide donated sperm, donated egg, donated embryo, or a gestational surrogate or gestational carrier to more safely or effectively carry the pregnancy. So that's like an incredibly quick overview of some of the treatments that are involved and ways to approach medically these issues. Again, I just wanted to point out some really amazing work being done by another of our PhD faculty, Dr. Nobu Hamazaki, in his lab down at South Lake Union. So he's been doing amazing work, and he's been published in Nature on stem cell work, and he's been producing even these gastroloids in the lab. One of his goals would be to produce viable oocytes for patients who no longer have viable oocytes themselves. And so that is certainly one of the holy grails of of our field, because ovarian aging is a big issue. As I mentioned, there's a disparity between sort of sperm and egg and how they respond to age. And we've got a population that is seeking to build families later on in life. And so that's an amazing, amazing work that Dr. Hamazaki is doing. So I've mentioned a few times fertility preservation as part of a really important part of what we do. This broadly just means, how can we preserve fertility for somebody facing medical treatment or some kind of limitation on their timeline, like they have to do something and can't conceive for 5 years, or they're facing chemotherapy or radiation or hormonal treatment or rheumatologic treatment that is going to impact their fertility. And so that's a lot of the work we do here at an academic center like this, that's affiliated with Seattle Children's and with Fred Hutch Cancer Center. And we see these patients immediately, same day, next day, always knowing that there's a real time crunch for many patients. And we see patients, importantly, afterwards, after their treatments, to assess fertility, to talk about sexual function afterwards, to talk about hormone therapy if needed, et cetera. So it's not just about the pregnancy. So we're seeing that cancer patients, not just for sort of classic chemotherapies, but also for some of the newer agents, can have a real impact on their fertility. Like one that we have been seeing a lot more are tyrosine kinase inhibitors that can have a real impact on fertility. So as these cancer treatments are changing, we are not keeping up as far as like good studies looking at the impacts, but we're living in real time some of the impacts and responding. And again, sometimes what people don't think about is that delay. So sometimes we'll have people, say, with breast cancer treatment, and they need to be on their sort of adjunctive hormone therapy for 5 years after their definitive treatment. That for women and for ovaries can be a real problem with putting off their fertility and their safe pregnancy. So the options that we have include freezing embryos, freezing eggs, freezing sperm, or freezing testicular or ovarian tissue. as well as we can also do things like move ovaries out of a radiation field. We can help a cancer team choose options that may be less gonatotoxic. So it's really about working together to figure out what's safest, most efficient for a particular patient. And one of the newer things is the ovarian tissue cryopreservation as well. The other important population to think about is our trans patients who may be seeking hormone gender-affirming care and would like to freeze tissue or eggs or sperm prior to that gender-affirming care. And there's research being done on whether we can do that, in the midst of the gender-affirming hormonal care, or should it be done before? Does there need to be a gap? This is all something that we, are keeping our eye on. And with all of this, it's really important to provide quick, inclusive counseling, timely referrals, and a very welcoming clinic to our populations who are facing these treatments. And I just wanted to, again, bring it back to UW. This is a picture of our team doing an ovarian tissue cryopreservation procedure. Our wonderful fellows on the left doing the actual oophorectomy, removing the ovary, and then Dr. Johnson, one of our fellows, and Amy Sullivan, our IVF supervisor, working on harvesting the tissue to freeze it. So that's something that we have been working on and are set up to do now. And we'll be working a little with children's as well. So in general, Children's Hospital tends to do more of the ovarian tissue cryopreservation because they have prepubertal children who don't have the option of egg freezing and stimulation. But it is something that in this particular picture, this was an adult patient who didn't have enough time and also wanted to keep the tissue for future hormone production to prevent early menopause. And so that's something that ovarian tissue will do that frozen eggs or embryos will not do. So it's a great option for some patient populations. All right, so I actually, when I decided to go into REI, I realized that it can be pretty ethically fraught area, and I was supported in doing a master's in bioethics. So I'm always really interested in thinking about the ethical and legal considerations to what we do medically in REI. And I'm sort of talking a lot, so I don't want to run out of time. But this is a list of some of the really compelling things that come up when we're thinking about what we do in our practice. As I've mentioned a number of times, first on our list is always access and affordability, and trying to make that as fair and equitable as possible to all populations. And that's incredibly difficult, when you're talking about some of the geographic and financial limitations to what we do. But that, I think, needs to be, number one in thinking that we think about when we're providing care. Donor anonymity has become a very big issue in recent years, appropriately so. When we used to use, decades ago, sperm donors, and then more recently, egg donors, there was this kind of feeling that anonymity could be guaranteed to the donor, and that it wasn't necessarily vital that the donor conceived child would have it ever connect with that person or have a sense of that person. And now it's very much changed to the standard of care being sharing that information with the child when developmentally appropriate, and having the understanding that with all the testing out there, that it's very likely that people can connect and find their donor. And so that's just part of our counseling at all times. And there's been, ASRM has been part of a donor conceived task force in the last few years to really talk about righting wrongs that have happened in our field and how to do this well. And then issues of embryo ownership come into play all the time. When embryos are made from egg and sperm, there's going to be two parties involved. What happens after dissolution of marriages or relationships, or if there's death in the family, And so that's always something that, we have to be careful of with our disposition forms and thinking about. Parenting age and ability is an issue that comes up. We're certainly very much about procreative liberty and allowing people to make autonomous decisions about what risks they take. But there may be some limits on that, and we have our own conscientious practice rights as well in our field. So, but parenting age, again, especially, has been pushed and pushed. I've been doing this for about 20 years now, 20 plus years, and we are accepting of parents at older and older ages, and I think that's appropriate, but requires also some kind of careful thought and counseling. Posthumous reproduction basically means reproducing after death, and we have a policy here at the University of Washington that basically involves, typically what we're thinking about here is, can we actually retrieve sperm or eggs after a person has been declared dead, basically. And so that's an incredibly interesting question, and who has the sort of rights to think about that and potentially try to access that. Something that's been very kind of elevated recently is this idea of pronatalism, and that basically can be a very fraught word. It can be considered a positive or a negative and challenging thing. And the idea is that we always have to consider that not everybody feels that the end all and be all is having a biologically related or genetically related offspring. And that sometimes when things are pushed in that way, in communities, in families, and within sometimes discordant individuals in a couple, then we can have, it can be a real challenge and cause a lot of distress. And sometimes also what can happen is that it can be okay for us to do that in certain populations and for certain characteristics, but not others. And so we have to be very, very careful when we're kind of valuing family building, that we're not being negatively pronatalist. And then PGTP, I could talk for a long time about that too, but this is a technology that's increasingly available where you can look at an embryo and test for many, many different genetic profiles that might predict somebody's risk of cardiovascular disease or short stature or tall stature or athletic ability. These are things that companies are proposing that that are available. It's unclear how accurate these things are, and it's also unclear the value to sort of a robust existence. And then again, who has access to these things and who should have access. So that's also an incredibly interesting thing to think about, but that is out there now. So I just want to end in talking about advocacy and education. So the World Health Organization, CDC, ASRM, and Resolve are all organizations that provide public education campaigns, support groups, resources with the goal to end stigma, improve literacy, and increase access. So those are places, and I'll have some references at the end. It's important that also state players, employers, communities also provide support and things to help people have families when they want to have families, and in an affordable way would be things like paid family leave, affordable childcare, and insurance coverage for things so that things are affordable, again, at an age and at a stage in life where it makes most sense. And then what can individuals do? They can certainly promote fertility education in their families and communities. They can support global access to treatment and then participate in awareness initiatives, which I'll show you in a sec. So this was something that, again, as I mentioned earlier, that we have sort of a center of excellence for infertility treatment for folks with higher BMI. And so Dr. Johnson and Dr. Vu, an anesthesiologist, and Judy Simon in nutritional sciences, and myself just published this. It was actually they asked us to write this up from this journal because they know that this is sort of a focus for our group. So we are just publishing this article, and it's really a call to other programs out there across the country to really think about what is needed to safely provide care to and not restrict care based on BMI. So we're excited about getting that out there. And then this is just another example, and this is a great example of a bunch of different stakeholders working together. So this is a screenshot from one of our advocacy days. And so there's an annual state advocacy day that Resolve puts on. The state of Washington, there's a national federal advocacy day. And then also the American College of Obstetricians and Gynecologists puts on an advocacy day as well at the state level. And so there's opportunities for providers, patients. This particular group involves 3 different REI practices in the community, which is wonderful. Involves a nonprofit group for fertility preservation, and we've got representatives from ASRM and Resolve on there as well. So a great collaborative group to advocate for what we need, which is improved access to care. So I talked a lot longer than I meant to. I hope we have time for questions, but in summary, infertility is incredibly common. Many people don't appreciate that, and treatable condition with far-ranging impacts, and is really not given appropriate support as a disease out there in this country and in the world. Awareness and advancements are growing, but we still need inclusive and accessible care and increased research in the field. And we think advocacy and education can help. So here's some resources. Again, they're pretty searchable. If you just look at WHO, ASRM, Resolve. SART is the Society for Assisted Reproductive Technology, so they kind of have a real focus on IVF. And then Reproductive Facts is great for patients. And the CDC has some good stuff as well. All of the programs that do IVF in the country have to report their results to the CDC by federal law. So that's a place where numbers can be searched. And finally, here is our division's email address if anybody has questions or wants to reach out and needs further information. And then our clinic number is here as well. Leave that for a sec. And then if anybody has any questions, happy to take them for the about 5 minutes that I left, sorry.
No, all good. Thank you so much, Dr. Ryan, for that jam-packed presentation. There's so many things that we went over, but I think we did get a few questions in the chat. I believe starting with this one, is it easier for women who already gave birth at a younger age to give birth again in later years than someone who's never given birth? And how effective uh, is IVF based on age? That might have been a two-prong question there.
Two-prong, yeah. Yes, well, in general, people who have previously had a child, especially if it was an unassisted conception, we think that that's a good prognosticator for being pregnant again, if it's with the same partner, especially. But even for those people, age will have an impact. It may not be as easy the next time. Things may have happened, exposures, etc. But generally, it's a good prognosticator. And then, yes, IVF is based on age. We can definitely overcome some age-related issues through like pre-implantation genetic testing. We can then test for chromosomal abnormalities that are more likely with age and then not use those embryos. But nevertheless, we still see slightly lower rates per embryo transfer with age with IVF as well. And then there's age limits. It becomes pretty futile after the age of 45, 46. So in our clinic, and that would be the age of the person producing the eggs. So at our clinic, we have an age cutoff of 46th birthday for IVF.
Thank you, Dr. Ryan. Oh man, there's a bunch more questions than I expected, but looks like another one here is there any evidence or research that supports the use of naturopathic treatments or supplements in addressing infertility?
Yeah, I mean, that's a really broad question. It depends on the exact treatment or supplement. Though there, it's hard to find great, well done data because part of the problem with supplements or naturopathic treatments is that they're not often, or they have a tendency to sometimes not be, similar across companies that are producing them. They haven't been maybe, FDA hasn't looked into each pill of this, particular supplement involves this much active ingredient. And so it's very hard to do a good study where you look at somebody who's been supplementing. There was a big folic acid and zinc supplementation trial that was done that was looking at for a sperm producing person, and that actually did not show any benefit to folic acid and zinc supplementation, for example. And there's been studies on like multivitamins and vitamin C and vitamin E, but it's a bit hard to find studies on many of the supplements that we see people taking these days, like coenzyme Q10 and inositol and things. So I do recommend that people talk to a nutritionist or a dietitian to just kind of talk about what they're because food is medicine. Judy, if you're on, I would be happy to hear me say that. But so it's definitely worth looking at kind of what you're putting in your body. But it's hard to find anyway, just broadly that like somebody seeing a naturopath or, somebody taking supplements, they're hard to control.
Absolutely. Yeah, it looks like there was a few a little discourse in the chat afterwards, talking about CoQ10 that you just mentioned as well. It looks like a couple people were recommended that, but um,
Yeah, we do have a lot of people that take coenzyme Q10, and I think in that particular case, I do feel like that's probably beneficial, but what I often tell patients is it's kind of gotten ahead of this of the research. And so now everybody is taking it, and so it's very hard to find a population that's not to study them and to figure out how much to take and what's kind of serum levels you're looking for. So I think it's kind of gotten away from us, which is, I don't think it's harmful. It may be beneficial. It's one of those things, but that's kind of the issue that we have with different supplements. I mostly don't want people to break the bank over taking a supplement that that might be or doing an alternative therapy that might not be effective and might, be very expensive. That's my biggest concern. And then with I would say some of the there, if you have a real mixed bag of supplements, a laundry list in this particular supplement, I do worry about there could be potential toxin exposure in there. So you do have to be a little bit careful.
understood. Thank you, Dr. Ryan. I think we might only have time for one last question here. Someone asked, in your experience, how significant is low ovarian reserve in the fertility journey if there are no other known complications?
Yeah, low ovarian reserve is really tricky. Um, there's a lot of people out there, including IVF practices, that are even, advertising like free AMH level this month for Fertility Awareness Month or whatever. And it's like, no, because the one of the measures of ovarian reserve is an AMH level that you can get a blood draw. And there's no evidence that that in isolation is predictive of fertility. Um, Certainly if it's at the extreme levels, very, very low, like undetectable AMH is concerning, and an AMH that's very high might be consistent with polycystic ovary syndrome. So it can give us some information, but generally in the middle there, it does not predict chances of getting pregnant without assistance for somebody who doesn't have a history of infertility. So similarly with what the ovaries look like, if they're a little, the volume or number of resting follicles is a little lower, it's not a great predictor. It does tell us how you might respond to an IVF cycle. It can give us some information, but it is unfortunately become something that a lot of people focus on when it doesn't predict when somebody may go through menopause or how their chances per month of getting pregnant. So it's limited.
Understood. Thank you, Dr. Ryan. And I know we are at time. I know there are a few questions that we weren't able to get to. So I'm sorry if I wasn't able to get to your question, but
I'm sorry I
Dr. Ryan,
talked
thank
so
you so
long.
much. Yeah. No, no,
You're
not at all.
welcome.
I think there was so much information. Also, congrats on your publishing your paper as well. I forgot to mention that earlier.
Oh yeah,
Uh, but yes, I just in respect of out of everyone's time, I just wanted to say thank you again, Dr. Ryan, for coming and taking time out of your day to present to us, and everyone for joining as well. Is there anything else, Jessica or Dr. Ryan, you'd like to say before we close out?
I really appreciate the opportunity to touch base with everybody and share what we're doing in our clinic. So thank you.
It was super informative. Thank you so much, Dr. Ryan. Very, very grateful for your time.
Yeah, my
And thank you,
pleasure.
everybody who joined us as well. And I hope you have a really wonderful weekend and a safe holiday coming up.
Amazing. Thank you so much, everybody. Have a
Bye.
wonderful